from breakthrough strategies to game-changing innovations and cultural shifts. You'll discover the lessons that drive real impact, and we'll dive into the moments that changed everything. Welcome to The Missing Piece with April Reed.
From the operating room to the executive suite, Dr. Laurel Soot had spent decades bringing clinical care and enterprise strategy with remarkable clarity. Today, she serves as the Chief Medical Officer at Providence Health Plan, where she leads across medical management, pharmacy, behavioral health, and value-based care for Medicare, Medicaid, and commercial populations. A board-certified surgeon and MBA trained leader in business analytics, Dr. Soot brings a system-level approach to healthcare, translating clinical and operational complexity into strategies that improve access, affordability, and quality. Her work has supported sustained 4-star Medicare Advantage performance and NCQA Health Equity Accreditation while driving meaningful cost of care improvements. Dr. Soot is known for turning complexity into systems that actually work, and we're so glad to have her on today's show. Welcome to The Missing Piece, Dr. Soot. Happy to have you.
April, thank you so much for having me, and feel free to call me Laurel. It's just a pleasure to be here and to have this opportunity to share my experiences with your audience.
Thank you. Really excited to dive right into your story. I would love for you to just take us back to the beginning. Why did you pursue medicine, and how did your career even get started?
Yeah, that's a great question because when people, look and ask me what I do now, and I say I'm the Chief Medical Officer for Providence Health Plan. Oh, that's interesting. But I would say that that's not what a 5-year-old would say they wanted to do, right? Or a 10-year-old. So how do you get there? And I think it really comes back to when you speak to most physicians and surgeons, I can really speak to since that was where I did my training and the group of colleagues I was in, it really is for many of us a calling. And I say that because of the amount of time that you have to dedicate in your teenage years, your 20s and early 30s to this career. And so it really came from a very, very deep sense of wanting to make a difference, to wanting to help, to seeing people having needs and how can you meet those needs. And that can be done in a social construct in many different ways. I mean, I think that's why a lot of people go into education as well. But for me, it was the physician, and I loved biology. The more I learned about biology and cellular biology, which was my major, and the more I learned about the human body, it just, the physiology was so fascinating to me and how it works. And so that's really what drew me to medicine. And then the decision to become a surgeon was a journey in and of itself. But I'd say that the decision to go into medicine was that wanting to help, that personal connection, and then just really, really interested in cellular physiology.
So, I mean, yeah, a lot of doctors go into medicine, but very few become surgeons. What did draw you to surgery specifically? And then what type of surgery have you been practicing?
Yeah. So that's a funny one too. So my father actually is a general surgeon. And people say, you want to be a surgeon like your dad? And I said, no. Actually, the answer was no. It was very, very clearly a no. Even after I decided to go to medical school, and I said, well, no, what's the no? And it was the lifestyle, which I had seen. You're working nights, you're working weekends, you're working Christmas, your holidays. And so I looked at every option outside of surgery. And my father did not push me. He actually said, look at different things. So I looked, I thought pediatrics. I love kids. They're so cute and fun. I looked at pathology. I looked at dermatology. I looked at different things in which there was a lifestyle to that I could see. And when I started doing my clinicals, so at the University of Washington for medical school, and I started doing my clinicals, and I kept loving surgery. I loved surgery. I loved the people, the colleagues, the surgeons, their mindset, how they looked at problems, how they solved them. They have a very funny sense of humor that's often very dry, that I really resonated with. And I kept doing these clinicals, and then I did what they call sub-internships. And I had actually applied for internal medicine residency. I was going to be an internal medicine doctor. And I started getting the applications, and I love my internists, but I started looking at them. I remember looking and said, you too can take care of gout and diabetes and hypertension. And I thought, I don't think I want to do that. And I think I want to be in the operating room. And the other critical thing was I was doing my sub internship, cardiothoracic surgery. I was in the operating room. When you're doing those, they're letting you do some little things and really operating under a lot of guidance. And the attending, so the physician in charge, the surgeon in charge, looked at me and said, Laurel, if you don't become a surgeon, this is your last day in the operating room. I will never forget that moment because I wouldn't be. There's no other, I would never, operating room is a very special place. And that stuck with me. And that's
You
when
knew.
I knew. I called my dad and I said, Dad, I think I want to be a surgeon. He's like, I was wondering how long it would take you to figure that out. That's signs. So then I changed. I went to the director and I said, I think I need to apply to surgery residency. And I was a little bit behind on everything, not too much. And he laughed and he said, same thing. I was wondering when you'd figure this out. I'm glad that's what you want to do. Let me help you. And so that's how I jumped into general surgery. And I just loved it. Yeah. I mean, it's that you're really tactile there in a very, very vulnerable moment for a patient. They put their life in your hands, literally. And so that to me was very special. And I just enjoyed, and because of the physiology. So going back, that anatomy, physiology, that's real time. That's surgery. That's what you're doing.
I think, what you're talking about is being drawn to something. Like you said, it was like you were called to it. And then and then even that, like, well, you can't take this away from me. I'm not done. I'm supposed to be here. That of, wanting to stay in the operating room. That's really neat. Having seen patients for so many years, there's got to be an element of predictability when you're seeing patients and outcomes in the sense of how did they get so sick, or why did it get to surgery, or how did it, why was it maybe missed? I know that has been really influential in your life from previous conversations that we've talked about. Will you share more about that passion of yours in, obviously your desire is to help the patient, but even to help them earlier on. Can you share more about that?
Yeah, I think that's when it became, so part of what my journey has been going and getting this MBA in business analytics, and where did all that even start? And it was really this data and seeing patterns. And I think that's when, although being a physician and surgery is one-on-one with the patient, you start to see these patterns. And the longer you're in practice, the more you see the pattern. And so that's what I began to see. And as a general surgeon, so I did both general surgery, which we now call acute care surgery, which is appendicitis, gallbladders, bleeding colon cancers, perforated ulcers, all those things. That's an emergency surgery. And I was also taking care of a lot of breast cancer patients as well, being the only female surgeon in my group. That just naturally kind of came to me. I enjoyed it. I really, really loved the patient interaction, which is very different than one you get in the emergency room with an acute finding. But we had this saying in surgery, and especially in the emergency room, we say it's the acute finding of a chronic problem, meaning that person never needed to be in the emergency room. Did they need surgery? Yes, probably. But had an algorithm been able to pick that up, or people see the signs and the pattern, we would have been able to intervene before they were in the emergency room. And with gallbladders, that's very true. Sometimes with appendicitis, very true. Definitely with colon cancers. And so I think that's when I started to see these bigger system issues of what is population health. Population health is being able to read the signs and the signals of a population and push and left shift it so that you're not intervening when it's an emergency or urgent. You're intervening at more of an active attack of a problem, or even if you get into preventative, which is very interesting, and how much can you really prevent versus just diagnose something in a much earlier stage. It's easier to treat. Those are the two things. So, but I saw that's surgery is the end result often of many issues that have been untreated. And even when I go back to internal medicine, so the diabetes and the hypertension, we see uncontrolled diabetes and hypertension then really impacting the outcomes in surgery because that chronic disease has not been managed well. And so that's when I started saying, we've got a problem that we've got to get much, much more in front of if we're going to improve the health outcomes, not only just of individual patients, but our populations and our communities.
Is there a patient or a moment that like really sticks out to you that began to define this, to where it's like the hospitals are treating sickness, they're not preventing it? Where can you think of a story that stands out to you?
I can. I think I've really got a couple. Both of them were in their 40s. Both were advanced cancers that I ended up operating on. One was a breast cancer, one was a colon cancer, a ruptured colon cancer. And the signs and signals and family history, which we're now understanding more of when we look at the genetic testing and for mutations, but that was really coming up during my active practice. The family history was so strong in both of these individuals for a colon cancer or a breast cancer in their 40s that absolutely, could we have found it earlier with screening and looking for it? 100%. And the signs and symptoms that they had were classic. But because they were both younger than your expected cohort for an advanced breast cancer or an advanced colon cancer, the signs and symptoms are kind of written off as an infection or irritable bowel or those things. And I look back and the writing was on the wall with a really clear personal history of symptoms and the family history combined. But those people did not have to have advanced cancer before they were diagnosed. We couldn't have prevented the cancer, but we certainly could have found it at an earlier stage easily. And that those two cases really resonate. So we've got to do something different. The writing was on the wall on this thing. We knew, and we didn't have the infrastructure to see that and to ensure that they understand what their risks are and what their family members' risks are. So I think those two very stood out to me.
It's really powerful. And of course, those two stories are only two. I'm sure there's lots of them. So having that influenced you, where did that take your journey? Because I know there came a pivot where you're saying, okay, I'm making a difference in surgery. I'm making a difference with these patients, but I want to make a bigger impact. Tell me more about that.
Yeah, I think, as I started looking at that, so during my time in clinical practice, I became our breast director for our two breast centers and worked with getting them accredited, which really meant making sure we were practicing at the highest level and that every physician involved with those patients, whether it was the surgeons, the oncologists, the radiation therapy docs, the radiologists, were all practicing at their highest license and with standards of care and appropriate evidence-based care. So after I did that and then became the regional director of breast health for the state of Oregon, again became really, really interested in this population health. Meanwhile, fast forward, I'm 16 years into clinical practice. I do at that time had two children in middle school and high school, a husband who's also a practicing general surgeon, aging in-laws, my own, and I'm open about, but I actually didn't take care of myself. I was so worried about my patients. And taking care of them that I ignored the signs and symptoms of a herniated cervical disc. And so I actually ended up having to have surgery myself emergently. And that could be a whole nother podcast on how to care for yourself, physician heal thyself and care for yourself, which I'm also very, very a strong proponent of because our training didn't teach us that. But during that time, so I took all of these pieces and things that were also happening in my life and had the opportunity to become a medical director at Providence Health Plan. And at that time, I was still very, very much in active practice. Although my neck and my surgery had impacted things, I wasn't stepping aside. I didn't have a plan to step aside. And I got this opportunity, and it's a provider-aligned plan. So meaning that our delivery system is integrated with the plan. So I was working with my own colleague, working with the other physicians. And I thought, this is so interesting because health insurance gets a very, very bad rap for lots of reasons, which I understand, and many of them are communication based. But the issue now is that you could see the entire thing. You can see patient care across the continuum, which you can't even today in a lot of electronic health systems, which means because it's all these claims, you can see what's happening to this patient. And then the thought was, this is population health. Who owns all this data and can understand the health? Who can move the needle to the left and say, ooh, we see now that you've been coded for a family history of this and this, and you've had these two things done. We need to get you in for your mammogram. Like, how you need to get you in for your colon cancer screening. We need to really reach out rather than this very reactive pay for the chronic disease versus let's get ahead of it and let's get you in and get you cared for. So that's how I shifted into the health insurance world.
That's incredible. I mean, it's inspiring in and of itself, from, practicing medicine all these years to obviously raising a family, to then getting diagnosed, overcoming that, and then now shifting into the executive leadership side. You ended up getting your master's as well. You're like, and by the way, I'll go get a master's on top of it all. What did you, in my spare time, what did you end up getting a master's in, and why?
Yeah, so that was my MBA in business analytics. And what I found, so it happened at the same time my son, my youngest, went off to college, and I'd been really, really thinking about it. So I started as a medical director in the health insurance, and then became AVP of utilization management, and then became the VP of utilization management. And as you are going up this ladder, you're seeing problems and realizing that just as physicians have a language in which they speak, and within 3 to 4 sentences, you can make it very clear a complex issue of what's going on with the patient. I didn't have that with the business lens. It's like, I knew there was a problem. It was a business problem, but I didn't have the vocabulary and the understanding of the mindset of those that would be in the room to listen and have the ability to change. And so I really realized I needed that business lens. I was part of our multidisciplinary clinic, had sat on our executive board, and had looked at P&L sheets, but again, it was all within a very limited scope. And I wanted that bigger, the real nuts and bolts of not just accounting, but financing, which that class in and of itself was brain push-ups to do finance. So kudos to all the CFOs out there. But then marketing, communications, B2B, what is that? It's a B Corp. I had no idea. And that, to me, it was really exciting, I think, also as a continuous learner, to open my eyes to a whole nother world. Because in surgery, we're not taught to market communications. You're like, I don't know. They just came to my office because so-and-so referred them to me. And so to have that language in the business analytics was that data piece. Really, now AI is, just exploded and all that. But it's predictive analytics. It's pattern recognition. It's what I saw in the emergency room. It's what I saw in the office with advanced breast cancer patients or others where the signs and symptoms were there. No one physician is going to see those bits and pieces. It happens, but not on a constant basis. But that's where I think the really exciting part of predictive analytics and business analytics is to be able to take that analytic lens, take those data points, and then now how do you help with that? So that's what that is, so that I can be able to have those conversations and understand where the others in the room were needed and when. And it couldn't have come at a better time with all the AI that's come through, and really understanding what it can and cannot do, and what it is and what it is not.
I love it. I mean, let's talk about AI for a second, because, AI's been around for a long time, but yet it's what everybody's talking to right now. And it's interesting. And I'm curious your opinion. It's like in healthcare. I mean, I've been in healthcare since 2004, but on the IT side, and it always feels like we're 10 years behind. Even when we think we're ahead, it's like we're still 10 years behind. But right now, I feel like in healthcare, AI adoption and advancement is happening faster than I've ever seen it in healthcare. Do you agree? And kind of, yeah, what's your thoughts around that? Because I think it's going to be life changing in a lot of ways.
Mhm.
I mean,
Uh,
it already is.
I absolutely agree. Caution the utilization of it without the oversight of physicians. And that's not to protect
Right.
my own, but when you take the learnings of a 4-year medical degree, a 6-year residency, and then the first 3 to 5 years of clinical practice are really, really critical to understand patterns, recognition, and care. That's 13 to 15 years of training. And to think that a very basic computer algorithm is going to see the nuances of that and understand when patients drop out of algorithms, that's my biggest concern. Physicians see that and they understand that and they can look at the algorithms and the patterns and say, yes, and yes, but
Yeah.
oh, this. And I don't think we've truly addressed the liability. Who is ultimately responsible when AI makes the wrong decision or says the wrong thing? And sadly, we're seeing that in where AI, when we're seeing people who have done things like had suicide by suicide or made some really, really sad decisions by really basing it on AI. Those are the things that kind of floated up. We're going to see that in medicine if we don't utilize it appropriately. I think the other concern is that we have operating processes that really haven't changed for medicine. And that's something I've been thinking about a lot recently is all of the training, everything we do to manage patients, how we see them is very what we call Halstedian. And Halsted was one of the old surgeons, in the 1900s. So putting on that business lens, we haven't changed the operating process, but we've added things to it. And we haven't stopped and said, is this the process right for 2026? Are we using our people correctly in 2026? Have we trained them appropriately for new processes and new technology? Or are we just putting these things in to say, oh, be more efficient in an old operating model that quite honestly is antiquated and needs to change? And so that's my bigger concern, but that's a tough decision because you're saying we're going to start all over. And they're like, we don't have time. We got to, we got to save money. We got to be more efficient. I'm really, and I don't say this to be like, we're doomsday. I'm really concerned about patient care in some of these situations because who's the oversight? And then what's the liability? And what does that do? So we're already talking about physician burnout and resilience and all that. When AI makes a decision that a physician is ultimately responsible for, that didn't have complete oversight or understanding, and they're held liable, even if you just lost another physician, and access is already an issue. So that's why physicians just have to be at the table of when this is being used. And I think one, and people say, well, give me an example or something like that. One that is really, I know many physicians are struggling with is we went from, old school was when you took a note and you talked to a patient, you scribbled it on a piece of paper and those were your chart notes. Then it went to electronic health record, which and you were like typing like a maniac and trying to template things. And then that doesn't work. And then we have all these regulations coming and say you can only bill and code if these things are documented and then this and that. So things start coming down. Again, the operating system has changed. Things are coming in that you haven't changed. I've got to document X, Y, and Z, like the paper chart. And so then we're doing that. Oh, we can't do that. That's too much. So then we hire people, scribes, to type for us because we can talk to a person and type at the same time and template and code correctly. And so then you have your scribes that are doing it for you. And that now is increased your overhead because really you've got two people seeing this person, not one. But with a scribe or like a dragon dictation that we used to do as well is ultimately the physician knows when it didn't catch something. They'll put a blank or a little asterisk. And a good scribe will put it in parentheses or asterisks or italics. Like, I don't think I got this quite right. The concern with AI is it does not do that. It hallucinates. So it puts in what it thought you said. And there's nothing that stops you to say, like, I don't know if I really got that right. So now you're going to ask a physician to sign off and not be able to scan a chart note and see like, oh, that's where the asterisks are. Like, that's where the underline is. That's where they didn't quite get it. And it's going to make errors. And somebody's going to sign off on that. And because it's going to try to think you said something and make it make sense from a medical decision-making standpoint, and it's going to be error. And we have not addressed that. And who is ultimately liable for an inaccurate chart note? That bothers me. I'm not, and people have raised the question here and there, and nobody, and if anybody out there has a great answer, let me know, because I do worry, because ultimately that is the physician's liability and who's protecting the physician in the utilization of AI to make them more efficient.
So interesting. I loved all of that answer because I see AI in the efficiency from an IT perspective, how to help you and help the physicians, but at the same time, that risk and the hallucinating that it does do. And it does fill in the gaps. I mean, I've implemented Dragon as well for years, and it was almost frustrating because it wouldn't get it quite right, but it made you as the doctor take your time to make sure your note was right. So it was almost like helping you because you're like, no, you're not, what I mean? But now AI, to your point, it doesn't. It assumes.
Right. And it assumes incorrectly.
Very interesting.
Yeah. So that's the problem, that I think we're using it in spaces it's not ready for. But I have no problems with things like, please scan to me just 200 pages of chart note and find the 3 MRIs that I need. Like, boom, 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 they can do that. Like, love that.
Pull them up to the top. Yeah, exactly.
Right. I need you to, if you could tell AI, I need you to pull the last 3 years of this lab. I need this pathology report, and I need this, and tell me if any of those is missing. And it would like, boop, and there you are, rather than shuffling through and looking and control F and I'm trying to find something. That's fantastic. And so there's parts of it that be absolutely fantastic. Or submitting an authorization to an insurance company, which everybody hates, and it says, and it pops up and it's like, you're missing this, or this digit is wrong. And we see that all the time when people think that the insurance company or a physician, a provider, thinks that the insurance company denied something. All right, no, we didn't deny it. It just, your code that you submitted in this diagnosis don't even line up at all. Like, we can't make this make sense. It's like, oh, a digit got flipped or something. Like, that's where AI would be. I think it can be incredibly helpful, is where human error is not being seen, and we could help with that. Like, that stuff that is streamlined. Like, it could just say, these two codes don't match. Can you please look at this? Like, oh, right, let's post that. And, or I forgot one digit, and it goes and boop, and then it's approved. Those are the things I think are really exciting about it. I just worry that people are trying to shove it into a clinical algorithm where it's not ready. I think it's where it's ready and when and within what process. But I do think it's going to potentially be very, very helpful in the health insurance space for getting claims paid and things.
Yeah, I love that. As we begin to wrap up, I want to circle back to your passion around prevention, population health, moving care further upstream, why the seat you're sitting in currently and your passion behind it. A question is, what do you believe has to change if we truly want to keep people healthier instead of only treating them once they're sick?
Yeah, I think that's a big question. And that gets back to kind of the whole operating process of, what does America really, really want from healthcare? And I think you have to get that question answered before you can really change things. And that's a top question. And people get back to, is it a privilege or is it a right? And I think it gets even more than that, than a preventative. Our entire industry, I can say absolutely in surgery, because I've seen it now on multiple levels. And I've sat now at every table of a surgical intervention, which is one of the more revenue generating for a facility, for a ASC, for a hospital. Cost the most from an insurance standpoint, is the highest revenue for a physician. Is our entire system is set up and rewards doing more. And that's fee for service, charging more, billing more, doing more. And it's not just the physicians, it's every part of health insurance. A facility makes the revenue by doing more. And now the drugs are so expensive and the costs have skyrocketed and are very, very different. The cost that we pay for specialty medications, for different types of medications in the United States, when you look at other countries in which healthcare is not the highest in the GDP, those cost differential is significant. And same thing with devices. Everything that goes into healthcare is set up to take care of sick people and to generate a revenue for taking care of sick people. If you do not do those, you make less. And again, that's my business. This was part of getting my MBA to really understand this so that you can say, do you really want, yes, it sounds good to do preventive care. We have healthier communities. We spend less money. Look at this GDP, but we spend less money. So whose revenue is that not? Because when you're spending the money, that's somebody's revenue. And therefore there's not magic money. I mean, it's going to get taken out of somebody's bucket and put somewhere else, or we're all going to globally, come around and say, yeah, we spend too much money. It means very specific industries are going to make less. And so I think we have to really grapple with that, because otherwise it's just FaceTime to say like, oh, we just want to prevent things. Like, well, where's the financial incentive to do that? And we have to have one, or come around and say, we're just spending too much money. Our financial incentive is to spend less. Oh, we've got some really good ways to spend less. And yes, you'll invest some in some areas, but it's going to be so much less. So again, breast cancers, colon cancers, talking to people, diabetes. I mean, with the GLP-1s exploding and the costs, and yes, they do a fantastic job for type 2 diabetes. The type 2 diabetes is overall a very preventable disease. You don't need to have type 2 diabetes at the level that we have it in America. And so that's where the real cost savings come in. But then you can see where what's happened in that area. So it's a loaded question. And I think that's the reason why is our financial incentive structure set up to take care of sick people. And we do a really good job at it. I mean, we do. Like, the quality is fantastic when they get care. But now we're getting to a point where people can't access care and they don't have the money. And we haven't decided whether this is a right or not. And so people are going bankrupt because of the cost of care. And so real people are suffering because we haven't figured this out. And so I think that's what, when I start to really look at it, that's concerning, but that's what makes my brain start like, can we do this better?
Yeah, I love it.
Can we get on the table and fix this?
I've interviewed other physicians and they ended up leaving the ER, other things, and starting like longevity medicine practices or, wellness practices because they wanted to do that very thing. So this is my last question, is for the physicians that are listening and that's resonating with them, the leadership, the C-suite. What is your advice? What's your advice? How do they make that difference? How do we start to reframe the way, healthcare is set up, to be more preventative versus just treating the sick? What's your final words of wisdom?
My final words of wisdom is, number one, you do it for the right reason. I would say that if you're doing it because you are burned out and don't want to practice medicine anymore, it's not because it's not a don't. It's what are you going to do with it? And then once you figure that out, so if it's a bigger ask, a bigger question, a bigger play, like I keep seeing this problem, and I think if I'm in a leadership area, I can make a difference and fix the problem, then go. Because we actually are really trained to be leaders. All physicians have been trained to be a leader. You're ultimately in charge of that patient. And again, going back to that liability issue, you're ultimately liable. So you are, in fact, a little mini leader every day. And you're running your clinic and you've got your schedulers and your medical assistants and all that. You are managing a team. You are also working not just independently. You're working with your colleagues, your physician partners. That's your executive team. And so nobody, there's not one is better than the other. You usually have a senior partner. That's kind of your CEO. And so you've been living in this environment in a different way. So when you come into a C-suite environment, it's actually very, very similar to clinical practice. And I'd say, especially for me in surgery, because ultimately that surgeon is ultimately responsible. And there are so many teams that you're working with. And the ability to see patterns, critically analyze, and make a decision based on the information and ensure that you've got the right information, but not analysis paralysis. That I just can't make a decision. I don't know. Ultimately, physicians are really good at making decisions. We have to gather data, diagnosis, information, clinical, and we make a decision. And we're okay with changing the path. But oh, that medicine didn't work, or oh, we offered this and we need to go backtrack. We're okay with that. Like, our egos aren't damaged when we say, like, we started on a path and now given more information, we're going to change course. And here's why. And we're also we've been taught to communicate, really taught to communicate with patients and to communicate again with our administrators in the hospital, communicate with our partners, and how we communicate is different based on the words that you use, the tone that you use is very different when you're talking to an 80-year-old grandma about her breast cancer versus the 32-year-old mother with mother of 4 with breast cancer versus your colleague who reviewed this MRI with me on this breast cancer patient versus the administrator when you need more resources to take care of your breast cancer patients. Each of those is the same, but it's a very different conversation and tone that you have. And I think we can lean into that. So the emotional intelligence of physicians in the C-suite, I'd say, is markedly different than some others.
I love that. Well, I know I've been inspired, and I love what you're doing and the impact that you're making, not only where you currently are, but just population health as a whole. So thank you for your time, for being here and for sharing your insights and sharing your story. I know I'm inspired. I know the listeners will be as well. So thank you for everything that you're doing.
Yeah, thank you so much, April. I really appreciated the opportunity.
Of course.
Every leader has a story, and every story reveals another piece of the bigger picture. What if the missing piece wasn't something you had to find, but something you were meant to become? Subscribe, share, and keep leading with intention. I'm April Reed, and I'll see you in the next conversation on The Missing Piece.